Dr. Claytor here, the reporter, surgeon, researcher, so I like to go by the name of Razor. And I've got here Dr. Alan Widgerow to talk to us about how mesenchymal stem cells have an amazing treatment option for patients infected with COVID. Dr. Widgerow.
Thank you, Brannon. So Dr. Widgerow here from UCI Tissue Engineering Center, Plastic Surgery. Essentially, as Dr. Claytor says, we're really interested in the mesenchymal stem cell capacity to really control inflammation. Okay, so really, what do we mean by that? The immunomodulatory capacity of mesenchymal stem cells, this ability to actually modulate the immune system, whether it's adaptive through different cell types, B cells and T cells, or whether it's innate from the exact acute reaction to infection or to foreign bodies, the MSCs, mesenchymal stem cells, are able to actually douse the inflammation and decrease the amount of inflammation before regeneration takes place. It's a capacity that's built into the cell because the cells are really there to replace and to regenerate injured tissue. And they do this through this whole mesogenic process. So they're able to form various different parts, bone, cartilage, muscle, bone marrow, etc. And we really talk about this being spare part cells. These cells really have the capacity to change into all these different cell types through this regenerative capacity. But in this particular situation where we're going to talk about it today, it's not this differentiating capacity that we are interested in. It's really this ability to control, before it differentiates, it has to control inflammation. So if we look at a scale and a balance between inflammation and regeneration, when inflammation is up, regeneration cannot take place. And we have to control inflammation. And these cells really have the capacity to do that. But not only that, some authors believe that the cells surrounding the blood vessels, called pericytes, are really the originators of many stem cells, including mesenchymal stem cells. So in almost all the tissues where we have a blood supply, whether it's fat, whether it's umbilical cord tissue, whether it's bone marrow, these pericytes that hug around the outside of the vessels, through their position on the outside of the vessels, are able to monitor exactly what's happening in that tissue. And when they need to, they will just release themselves. They'll become activated there. And once they become activated, they take on these various different functions. The functions being trophic effects, that is basically controlling the environment, that local environment for scarring, for forming new blood vessels, etc. But what it really does before those trophic effects is it forms an armor around the traumatic area with this immunomodulatory story. That armor really creates a kind of defense mechanism so that different cells and different foreign materials can't infiltrate there. But more importantly, it stops the inflammation in its tracks so that this trophic effects can take place. And then it has these antimicrobial and other effects as well. But essentially what's happening and what we're very interested in is these immunomodulatory effects that really do bring down the inflammation in that situation. So if we look at the COVID in a little bit more detail, I know that, Brannon, you've been involved in some of the diagnostic situations. Do you want to have a few words there?
Absolutely. Thank you so much. There is a tremendous amount going on trying to figure out what's the best way to actually determine a diagnosis. And certainly we're all very familiar with the swabs that get put down people's throats, and that detects the RNA that's actually in the virus. Here's the virus up in the upper airway. And so once that viral load comes from the nasal pharynx down into the lungs, we start seeing the virus becoming incorporated into the host, into the person. It binds, it comes in, and it takes over the cellular mechanism of the cells itself and starts making more and more virus. And then what happens is that the body's immune system breaks down that little piece, and on this APC, this antigen presenting cell, promotes a little bit of it out there on the periphery, and the body starts developing cellular immunity as well as humoral immunity. And so these are the T cells in the cellular and the B cells in the humoral. And one of the things that leads to the complications of the disease, which ultimately can cause the patient to succumb to that, is the body's immune response to the viral infection, leading to what's known as the cytokine storm. So at this point, Alan, I'll give it back to you.
Yeah, so just to go in a little bit more detail there, it's very interesting because how does this virus get in there in the first place? And what happens is the virus has these little, you'll see the pictures with these little spike proteins around the side. They always have these little parts that are sticking out of the side of the viral particle, and that's called spike proteins. And these spike proteins are attracted to the receptors on the surface of the cells. The cells, not only in the lungs, but the intestines, the kidneys, the heart as well. And these are ACE2 angiotensin converting enzyme 2 receptors. And so that spike protein really gets attached to those ACE receptors there, and that sits on the surface of the cell. Then from the cell itself, it gives out an enzyme called a protease, which actually splices that, and that protease is called TMPRSS2, but that protease actually splices that spike protein, which allows it to fuse with the cell membrane, and that's how it gets into the cell. Now, once it enters the cell, then you start getting this whole cascade that Brannon just talked about. So what are plastic surgeons like us doing, talking about COVID, and why are we really interested in this? Because this whole sort of situation sparks memories in us of patients that had had major burn injuries. And what happens with major burn injuries is you have this tremendous amount of injured tissue, which is full of foreign protein. And that foreign protein releases different molecular proteins. We call them DAMPs or PAMPs, either from the damaged tissue or from pathogenic infections. And those really do signal the cells and get into the cells, much like the COVID virus gets in. And when it gets into the cells, it produces this huge inflammatory reaction called the cytokine storm. And in our case, we used to call the SIRS, a systemic inflammatory response syndrome. And that really caused multi-organ damage and failure. And this is very much the same situation that happens. When the COVID virus gets into the cell, it starts with this huge inflammation. You get exudates, you get release of fluids, and these you get this response of the lung where they can't actually catch the breath, where they can't get enough oxygenation. Very similar to that. So what we're really looking at now is saying, okay, is there something we can do that will douse the flames of that storm and decrease the amount of inflammation? So when we started looking at that, and when I looked at I said, hang on, I've seen this before. This is SIRS happening again. And one of the things that we really need to do is try and decrease the inflammation. And we had a number of different agents that we used in the past, but they were all sort of targeted to one particular cytokine, an IL-6 or something like that. And I said, well, in mesenchymal stem cells, we've seen this every day, that before regeneration takes place, we have to have a control of inflammation. They would be ideal to use in this situation. So I started searching for proof of where this had been used, or if anybody had used the mesenchymal stem cells to really control the cytokine storm. And I found a little trial that had been done in China, which is really interesting. This trial done by these particular authors, Ling and Co., where they had taken a number of these patients. But really what we're aiming to do, and what this whole talk and this discussion is about, is try and get patients before they are ventilated, get into the stage where the cytokine storm is either just starting or just before it starts, and before the lungs really close up and the saturations drop dramatically. That's the time to get in with your therapeutic intervention, because as we know, when they get onto the ventilators, very many of them don't get off, unfortunately. So we want to try and prevent that. Well, how do we do that? So essentially, part of the whole process is that with the mesenchymal stem cells, they manage to convert a lot of those inflammatory cells from this huge inflammation to an anti-inflammatory makeup. Originally, when we get in with acute inflammation, you get a T1 type of cell, which is a pro-inflammatory type of cell. Same thing with the macrophages. Those macrophages are M1 macrophages, which means they're very pro-inflammatory. And that means that they secrete, the secretomes, or the substances that secrete, are very much pro-inflammatory. So it's TNF-alpha-1, it's interferon gamma, it's IL-1 beta, it's all these real pro-inflammatory secretions that affect this area. And once inflammation is over, it converts from this T1 to a T2, which is an anti-inflammatory situation. Unfortunately, with this acute situation where it's overwhelmed, and sometimes with chronic wounds, we get a situation where they're not converting fast enough to the T2. What does the T2 do? It secretes then anti-inflammatory profile. So IL-10 is really important in that because it's a nice blanket anti-inflammatory. IL-4 is also important, also in terms of anti-inflammation. And then you get anti-TNF-alphas and all sorts of secretomes that actually fight against that or convert that pro-inflammatory milieu into an anti-inflammatory milieu. Mesenchymal stem cells push that whole balance towards this T2, M2 kind of situation. And that's what's so important about that. So here we can see it in a little bit more detail. Essentially what we're doing here is, if you look at the green arrows, the T regulatory cells are really pushing out. So we're converting T cells from these dramatically pro-inflammatory to the anti-inflammatory situation of IL-10s and IL-4s, which are so important for anti-inflammation. We're also then decreasing through a whole process the interferon gammas, the TNF-alphas, and all the pro-inflammatories. So now we're heading towards a balance where we're getting controlled or neutralizing this pro-inflammatory milieu. So if we look in a little bit more detail at this trial or the pilot study that was done with these cases, you'll find that with these patients, they took 10 patients, a small trial, but 7 of those 10 really were divided into one critically severe. In other words, they were already ventilated, the cytokine storm had already taken place. 4 were severe type, where their sats had already gone down, their saturations had gone down, poor oxygenation. And then 2 were the common type, where we see, they were starting to get symptoms. We know they were positive and they were getting their symptoms, but they hadn't quite got to the saturated part. And then they used 3 placebos, or really just looking at severe patients, but treating them with a standard of care that was normally used, that we're all using on an everyday. What do we do? A couple of the therapeutics that we use, and then we put them on the ventilators and hope that the immune system is going to get under control. So very interestingly, when they looked at that, and they looked at the critically type and the 4 severes and the 2 common types, all of them had tremendous success. So you'll see that when we look at the lung X-rays in particular, you'll find that these patients, from going from a whiteout in these lungs, had improvement right across the board of critically severe types and the common types. And you'll see in the next slide with the lung changes that took place, quite dramatic, that from the treatment, you can see that from almost a whiteout situation where those lungs were infiltrated with fluid and with a huge amount of inflammation there. And this is an ARDS kind of syndrome, acute respiratory distress syndrome kind of appearance. And you can see how this really improved over time, and the lungs cleared after the treatment situation. So a very dramatic response there. Yeah.
So these are CT scans, and if people are able to read this, what they could see is that this is when the patient first came into the hospital, getting worse. And actually, this is on January 30th. It says down on here that January 31st, so right between here and here, the patient was given the mesenchymal stem cells. Can you describe why it looks like the lungs are a little bit worse from here to here? And then again, here we are on February 9th, so we're about 10 days out after the actual treatment, and then they don't have the corresponding image here, but clearly you can see that by February 15th, the patient's dramatically better. Can you describe why you think that 1 or 2 days after the treatment, the lungs actually look a little bit worse?
Right, because there's always a lag phase in terms of the therapeutic taking place. So what's happening is you're getting the accumulation of fluid that has probably been there for a couple of days. And as we know with X-rays, CT scans, all of this, they start manifesting a little later. So the white that you're seeing is probably that had been there for a period of time before. And then to get those macrophages and to get the cells under control and working efficiently, that's going to take a bit of time. So it'll get slightly, and you see this in the blood tests as well, that you get slightly worse and then it starts dramatically improving. And there's a good indication. If you look at the C-reactive protein, which is a general sort of response to inflammation or something going on that is that the body's mounting a response to. Essentially, we can see, look at that, it's January 31st is when it is applied, and then it goes up quite dramatically the next day, but then look at the response after that. We get a beautiful response where it really does go down quite dramatically over those days, and those really do coincide with the CT scan appearance and with the patient's general health.
Can you extrapolate and spend a little bit more time talking exactly what you mean when you say the inflammatory response is being reflected by the C-reactive protein, and therefore how these mesenchymal stem cells that were given at this time point on January 30th here, and how they are impacting C-reactive protein, what that means?
Well, again, C-reactive protein is just a general response in terms of inflammation, and that activity is going on. And we know that there's a huge amount of activity going on in terms of the cytokine storm, but just as much activity is going on when you start applying the cells, because they have to now go through the conversion process that we talked about from the T1 to T2s and M1s to M2s. And that's going to take quite a lot of action and quite a lot of activity. And it picks up this general activity going on from this new capacity conversion from inflammation to anti-inflammation. And once the anti-inflammatory capacity is increased and taking over, then you see this gradual improvement in terms of the C-reactive protein. In fact, it's not even gradual, it's quite a dramatic improvement in terms of the C-reactive protein. So, again, we've talked about these various elements, but really looking at this in very broad terms, the inflammation is created by these secretomes from the cell. So what is secreted from the cell, interleukin-1, TNF-alpha, these go through various sort of different transitions. But one of the things that is secreted by, or one of the many secreted by the mesenchymal stem cells, is this anti-TNF. So it's a TNF-stimulated gene protein, TSG6, and that, in fact, is almost an anti-TNF-alpha feedback loop that really decreases these pathways, these inflammatory pathways. So the NFKB is a strong inflammatory pathway. And really what you're doing is you're antagonizing the effects of the interleukin-1s of all these pro-inflammatory cytokines. And this has been really reflected over many, many publications and many studies through the ages. Important here, the LPS, or the lipopolysaccharides, TNF-alpha, nitric oxide. This is what I was talking about with DAMPs and PAMPs, and the same sort of thing that we saw with the inflammation from burns, is that this material that is injured, and you get this huge amount of injured tissue, and that actually creates this damage-associated proteins that are secreted, and that actually switches on. If it doesn't overwhelm the system, it will switch on these macrophages from the injured tissues, and then it will activate these MSCs to get into the area. And the MSCs will get onto those macrophages and say, let's try and convert as quickly as possible to the M2 macrophages. And basically, that will start that done through a secretion of prostaglandin E2, but that converts those macrophages. And once they convert it to the M2 type, then it starts pouring out things like IL-10, and the IL-10 is an anti-inflammatory, nice anti-inflammatory component. So it sort of orchestrates everything. MSC is there to create healing, to create regeneration, and it will do this by really taking that situation and changing the milieu so that it's more suited to regeneration. So if you have a look here on the left-hand side with our the initial story, injury or infection, in this case infection, it's really going to start twofold. It's going to release macrophages, M1 macrophages that will release these IL-1s and IL-1 betas and TNF alphas that are really strongly inflammatory. That will affect the cells. The cells will then pour out white cells and other inflammation. But at the same time, it also releases the MSCs. And the MSCs have this capacity to block that reaction from the TSGs that I talked about, prostaglandins, IL-1s. So you're getting a blockage there. You're getting conversion of those macrophages to an M2 macrophage, and that changes the whole response of the body. What are the advantages? Well, you know, from a point of view of targeting with this particular mesenchymal stem cells, we have a blanket response, as you saw. It has the anti-TNF, it has the IL-10s, it has a whole lot of different secretory functions that will really across the board decrease the inflammation rather than targeting one. The same story with immunosuppressives. We looked at this from an immunosuppressive perspective of MSCs right in the beginning. And one of the advantages is that it would hone down to the areas of inflammation. So instead of like just these blanket immunosuppressive drugs that will affect the whole body, the MSCs find where the problem is, where the inflammation is, and they hone down there, decrease the inflammation, and then they can actually begin their function of tissue damage. And by suppressing the inflammation, it allows that immune response then to take over and for the healing capacity to take place. And the immunomodulatory function of the MSCs is absolutely ideally suited to the cytokine storm that we talk about here. So in these patients where we want to try and avoid ventilation and to try and control the cytokine storm, basically the mesenchymal stem cells come in, they affect the immune system by controlling and balancing it. They secrete these factors, the anti-IL, the IL-10s, and they control the IL-1 betas, and they control the TNF alphas. And basically, with the prostaglandin E2 as well, they stimulate this conversion of the M1 to M2, and again, that pours out more IL-10s. So really what we're doing is we're adapting the immune system to actually control the inflammation and to change the milieu into one of regeneration and healing, where the body can now cope with this and reverse the situation of this huge amount of inflammation taking place.
So unbelievably fabulous summation of a very, very good paper, as well as tremendous demonstration of improved clinical results from China. Can you spend some time talking about why you think mesenchymal stem cells may be more beneficial than plasma treatments that are so popular right now, and why this paper may actually be demonstrating superior results than convalescent plasma treatment?
Yeah, so, you know, rather than sort of pitting one against the other, I think there's a specific area that is really important for this. And why I'm pushing this is whereof the biggest problem here is not only the virus and the amount of people that are affected. The biggest problem is obviously the deaths. And why are the deaths taking place? They're taking place because we cannot control this infiltration of the lungs and the saturation or this desaturation that's taking place in the lungs. And it's all very well supporting them with ventilation, but it's not actually changing that inflammatory milieu that's taking place. You'll find that most of the companies that are producing them are either from umbilical stem cells or from bone marrow. There doesn't seem to be a huge difference between the three in terms of the efficacy. So wherever one can get them, that's great. They'll passage them, in other words, they'll grow them over 1 or 2 cycles where they can get a huge amount of cells. And one needs to actually source these from companies that have GMP laboratories that have been certified and that have FDA approval of these cell lines. And now with this expedited approval taking place now, there are quite a few companies that do that. Dosage-wise, it seems like 100 million cells per kilogram is probably what we're looking at in the dose. So anywhere
1 million or just 1 million?
1 million, I'm sorry,
No.
quite right. 1 million cells per kilogram. So it means about 100 million, probably for anywhere between 60 and 100 million for one dose. And what you do is intravenously, you apply this slowly, 40 drops a minute or so, and over something, or 4 drops a minute, over 40 minutes, you can get this entire supply intravenously applied. And it's one dose, and that is it. So it's a very simple application. This is, but where the limitations are is that you have to have the sources that can source these. The companies that I've spoken to produce billions of cells, so there shouldn't be a problem in terms of the amount of cells that we can do. But again, for the area that we're using it, this is not going to be mass produced like a drug. This is going to be used for these patients just when they're starting with a ventilation story, and let's see if we can save lives with it. That's why I'm trying to push this approach.
It's absolutely fabulous. And it certainly seems like they've used it in China, and I know there's another paper in Israel. And to both of our knowledges, we're not aware of anybody who's doing this in the United States. Is that correct?
Yes, that is correct. And I'm sure there are people using, mesenchymal stem cells have been around for a while, and those of us that are familiar with it in the lab and using them, for me, this is just a no-brainer. It's a natural area. So I think they will start using it. But I would love people to start using it sooner rather than later. And I think what needs to happen is we need to get a PI who is a pulmonologist or an internist that's really interested in this, and they can drive that from their perspective. It's a relatively easy story to get going if you have the resources or the sources for the cells. Really, to get this underway is a fairly easy process, and it could be very dramatically life-saving.
Sounds absolutely just paradigm shift, groundbreaking, enormous opportunity for really changing how we look at these patients once they become sick. Let me ask you another question. Do you think that this treatment could be applied to a patient earlier in their admission to the hospital? So far, we've talked about patients being treated when they get to that severe state just before they really needed to be intubated. Do you think there's any benefit to giving this before somebody starts getting into a cytokine storm?
Yeah, so there may well be, but it's like anything else where we find a therapeutic. You want to get the hero indication sorted out first, and for me, the hero indication is really getting these patients away from the ventilator. If you can avoid the ventilator and we're at that phase, then if that seems to be successful, then you start expanding it and saying, okay, where else can we use this? Initially, there was fear of using these cells because these are off the shelf. These are taken from patients initially. And how can we use cells from a patient and put them into a different patient? Well, essentially, we've seen with the HLA status that basically they have a very a low HLA1 status and no HLA2 status. In other words, what happens here is that they are immune, not even privileged, but they're immune evasive. In other words, there doesn't seem to be a reaction to them. So the capacity of using off the shelf is great, which is a huge, huge advantage from that perspective. And then, as you say, with the indication, let's try with the life-saving indication, and then see if we can expand this into areas that may be beneficial down the line. I think that you're right, that if we can prevent the cytokine storm in the first place from even building up, we're going to have a tremendous impact on the disease.
Well, it really speaks to what you pointed out, which are the immunomodulatory effects, and minimizing that very massive immune response. Because ultimately, patients who get better, it's because their own immune system was able to attack and defeat this virus. And it's really the people who are dying are the ones who are having an overreaction effectively.
That's the irony. It's just working too much. That immune system is hyperreactive, and we need to try and get it down to a level where it's controlled, and then it'll do what it's supposed to do.
Well, Alan, I can't thank you enough. This is fantastic. I'm going to make sure that as many people as possible see this.
Well, Brannon, at the end of the day, thank you for the opportunity. Really, this is just about getting a therapeutic option out there and for people to use it. And I think it can really make a difference there. And I would hope that they start using it sooner rather than later. So thank you for the opportunity, and thanks to all of them. everybody that's been listening.
All right. Take care. Bye.
Bye-bye.